paraphrase, you're actually saying how you actually keep a research team on track, keep the review moving and focused, and also to how do you actually choose which quality assessment tools that we will use. Okay, so they're all really relevant and highly topical questions, and I guess they're the questions that we all struggle with when we're asked or focusing on doing a review. So if we, so if you were to name one thing that you wanted to improve, does that really reflect that list? Sorry, Newcastle, you can't see that. Does that list really reflect what you actually want to improve on the board? Yep, so there's nothing else you wanted to add? Yep.
I think efficient data extraction.
Okay.
Just trying to cut down on that confusing amount of time.
Yep, efficient data extraction. Okay. It's actually really timely, I think, that we're doing this presentation because Tim, Nicole and I are currently doing review. So we've been struggling with all of these items, and we'll probably during the course of the next hour or so actually share some of the strategies we've employed to sort of manage that, because we've got a really tight timeline to do this. But with that, I'd like to introduce my colleague, Tim Luckett. So Tim's a Senior Research Fellow, as I mentioned earlier, within the Centre. And Candice, we might need you to help us just get the next slide up. So Tim's actually going to take you on a quick overview. Candice actually sent out a number of articles for you to review, and hopefully you might have had a chance to have a look at the article. But that's actually quite a helpful. It's not necessarily the perfect or the most definitive document in terms of reviews, but it's probably the most comprehensive and the most recent, and it gives you a good overview in the very different types of reviews. So I think just to get us started, what I've asked him to is really a navigational guide to give you some frameworks to think about the different types of reviews, because all of us have actually heard of a Cochrane review. I imagine. Has anyone been involved in a Cochrane review? Okay, Donna, so do you want to tell us what share us your experience about the Cochrane review?
I have to declare conflict of interest because I was heavily involved in the Cochrane collaboration for a long time. I've been involved in 20 Cochrane reviews, but I'm also an editor and peer reviewer.
Fantastic.
So you want me to share my experiences?
Yeah. So what are the three strengths of the Cochrane review? Perhaps
the strengths are the methodological rigour.
Yep.
And also the collaboration as an organisation. It's been involved in a huge amount of development around systematic reviews, particularly around intervention and just a lesser extent, but diagnostic reviews. We still haven't really been able to get it happening with kind of prognostic, non-interventionist type reviews. Around the epidemiological and non-randomised control trial, which then still needs to be work done. It's a very lengthy process. I think that's probably a limitation. And one of the major conversations I've had over the years with Cochrane, including when I was on the steering group, was around methodological rigour as opposed to timeliness and supporting authors, because I was the author representative, so that was always a major concern of mine.
Good. And where are you working now?
Western Sydney and HG.
Okay. Get Donna's email. That's actually fantastic. It's wonderful to have someone who's been so heavily involved in Cochrane reviews, because they're actually, they're to me like the absolute gold standard of reviews. But sometimes it's not always possible or feasible to be able to do a Cochrane review. And today we are not talking about Cochrane reviews. So it's great that Donna is here and has sort of signposted that. And now I'll hand it over to Tim, who will talk about different types of literature reviews and the synthesis.
Thanks, Jane.
Is it on, I'm presuming?
It's coming through the system, but we can't hear it here. Did everybody hear Jane okay?
It's a bit quiet. This is the microphone for here, is it?
Yeah, I think that's right.
Okay, maybe I'll just try to stand here with
No, both go through the system.
Oh, both go through the system. Okay, okay. Yes, so thanks, Jane. And the reason I'm talking about synthesis very hard on the heels of types of literature review is I think really these days there is only one kind of literature review, and that's a systematic review. You'd be really hard pushed to get a review, anything other than a systematic review published these days, unless you're an absolute expert in your field, and a journal may actually approach you, to give an expert overview of the field as you see it. But for the rest of us, I think systematic review is absolutely the way to go. Having said that, I think systematic review is compatible with various kinds of synthesis, and we'll talk about that as we go. I'd like to start with a bit of a terminology health warning. So this is terminology, as in respect to most things, is constantly in flux with regard to reviews. It's changing all the time. You'll find authors use terms in different ways, and particularly if you look back, through publications over the years, you'll see terminology used in very different ways. So I think really there are some golden rules here that keep you safe. It's like, not straying off the path through the woods. And essentially, if you stick with these checklists, published checklists, it's validation by publication, essentially. So most journals now will expect you to report your systematic review using PRISMA, the PRISMA checklist, and hopefully many of you are familiar with that. It's freely available up on the web. There are other checklists for observational studies, meta-analysis, that's the loose one. OnTrek is for meta-synthesis, and I'll talk a little bit about those later on. And then there are other checklists which aren't specifically for systematic reviews, but are still very useful when you come to your synthesis, such as the TIDIA checklist, which is about consistent reporting of interventions. And that's really useful for complex interventions, which of course probably is the focus of today when we talk about translational research, implementation science. We're often focused on those messy kind of complex interventions, health service interventions, not the nice neat trials, which are rather easy to report. And that's where these checklists like TIDIA come in really, really useful. Having said that, the literature has come some way, but not all the way, in terms of reporting in a very thorough, comprehensive, detailed way, things like interventions. And you'll find that nearly all systematic reviews, and Cochrane's are no exception, conclude by saying, with a plea to the sort of authorship in the field, can we please start to report our interventions in a more reproducible, clear way, a transparent way, so we all know actually what people are doing, and we can compare and contrast results, with a view to what people have actually done in terms of intervention. We're still a long way from that. So the golden rules are really stick with these checklists, particularly PRISMA is absolutely required by most journals, but it's important to emphasize that's a checklist for reporting. It's not really a checklist for actually doing the systematic review. So PRISMA sets out headings such as your search, your eligibility criteria, your approach to synthesis, the kind of summary measure you've used, but it doesn't actually give firm recommendation on what the appropriate thing to do in each of those areas is. And that's really because there's usually more than one way to go. And it's provided that you give a rationale for each key decision, and you're very transparent about that, and PRISMA is really all about just being transparent, so people can see what you've done and make up their own minds about whether they would have done things a little bit differently, what the flaws are in the approach you've taken, and no approach is 100% perfect. That's a good way to go. So Jane mentioned that some journal articles were circulated, and they included Grant and Booth, and hopefully some of you had a chance to quickly glance at that. If you didn't, I'd encourage you to have a quick look. It's an interesting paper. It was published in 2009, and it's from a health librarian perspective on the different kinds of review that there are. And it's partly interesting as a historical document, because as I've mentioned, terminology changes over time, and I think already some of the terminology in that paper is a little bit out of date. But it's it's nonetheless very useful and helpful, partly because it classifies the review types according to this taxonomy of search, appraisal, synthesis, and analysis. Now, I'm not sure about the synthesis analysis division there, and I think probably, you know, we don't need to worry too much about that. But certainly in terms of the way that the search is conducted, in terms of the way that the bias is assessed, as Donna mentioned, and then the approach to synthesis, I think those really are key defining features. And increasingly, I think it's mostly about the synthesis is really the distinguishing characteristics. The other interesting thing about this Grant and Booth article is it acknowledges that trade-off between rigor and relevance. And Donna has mentioned that timeliness is one factor. You know, that if you just go to the nth degree in rigor, as Cochrane reviews do, sometimes by the time you actually come to, you know, it would be nice to get the results out a little bit quicker sometimes, particularly in a very fast-moving field. Now, Cochrane, of course, regularly updates its reviews as well, so that it manages it, that problem in that respect. But I think there are also been quite a lot of criticism levied at the Cochrane approach in terms of them setting the bar so incredibly high for the quality of research that they will usually include in their review, that they very often spend a year doing a review and then conclude that there are no studies, and therefore we can conclude. And for the clinician who's working with patients, that's really not very helpful. And you know, the kind of response that you hear from clinicians to that is, well, come on, there must be something you can tell us from all of these studies that have been done, even if none of them are absolutely a gold standard RCT. And I think that's probably true. There probably is something you can say that's useful from literature, whatever the quality of the studies. And that comes down to your synthesis, I think. Now, many of you may have heard in the past this term narrative review used as something of a bit of a pejorative, you know, oh, it was only a narrative review, that's not a very good thing. I think actually that the field's moved on from that, and what you're seeing now is systematic reviews with a narrative synthesis. And a narrative synthesis is just a synthesis when you can't do a meta-analysis. And in fact, many of the Cochrane reviews actually end up doing a narrative synthesis as well, either because they can't do a meta-analysis because of the heterogeneity, that is the difference between the outcome measures or the populations involved in the studies, or they'll do a meta-analysis, but then they'll also do a narrative synthesis on top of that, which unravels some of that heterogeneity. Okay, and we'll talk a bit more about that later. The other couple of minor points here are that Grant and Booth defined an overview as a summary of literature, sort of a bit like the old version of a narrative review. And they talked about an umbrella review as a review compiling evidence of multiple reviews. And I think now, thanks to Cochrane, you know, we're usually using overview to mean the latter there. You know, an overview is a review of reviews now, more or less. The other interesting thing is that they omit mention of integrative review. But they mention mixed methods review, and I think now more of the terminology is around integrative review for reviews that combine both qualitative and quantitative. And they also place systematic review in contrast to meta-analysis and critical review, whereas PRISMA, which I've already highlighted is really the gold standard in terms of reporting, actually says quite clearly that those two terms are not incompatible. And in fact, the systematic review part of the terminology really just refers to the fact that you have had a very kind of rigorous, reproducible, transparent approach to formulating your question, you know, identifying, selecting, appraising the research, and so forth. And that actually doesn't say anything about the approach to synthesis you've taken. And therefore, you can have a systematic review and meta-analysis, systematic review and narrative synthesis, systematic review and meta-synthesis, indeed, and various other critical synthesis would be another example. So really, a synthesis is just a method of handling data and combining the results from more than one study. Now, somebody has highlighted, you know, the issues around data extraction, and I think it is actually not always clear where the data extraction ends and the synthesis starts, because I think right from where you're starting to pull out the key details about studies, usually into some sort of electronic pro forma that you've designed to make the job easier, you're already starting to think about ideas about synthesis. You're already starting to essentially compare and contrast the studies, which is really what synthesis is all about. And I really think of synthesis as analogous to qualitative analysis, whether it's a meta-synthesis, which is of qualitative research, absolutely, or indeed is a narrative synthesis of quantitative findings, or even if it's a meta-analysis, which is using statistical approach. In all of those cases, you are still qualitatively comparing and contrasting the studies that you are including in your review to some extent. And I think that process starts right from the word go. In the same way that qualitative research analysis really starts the first time while you're conducting the interviews, certainly while you're transcribing them and you're doing your sort of initial coding. You're already forming ideas about the thematic analysis that comes later. And I think it's really analogous to that. But the best approach to synthesis really does depend on the nature of your research questions, of course, the results that you're dealing with, which of course are in turn dependent on the study methods and the design of those studies that you're including. So I've already mentioned that really the three key kinds of synthesis are the meta-analysis, which is statistical techniques, narrative synthesis, which really is what it says on the can. It's a form of storytelling, which in fact I think all reviews are, and the meta-synthesis, which is around qualitative research more specifically. So again, let's have a little look at this term, integrative review. Now that term has been around since the 1980s, but in fact it's interesting to note that it was really around the 2000s that we really started to see its current definition emerging, and now it really is usually used to mean reviews that include both quantitative and qualitative results. But even so, it doesn't actually have to include quantitative and qualitative. Sometimes it's used just to include kind of diverse methodologies. So you might have limited to quantitative, but you might be including both evaluative and descriptive studies, for example, because you may be looking at both evidence of effectiveness and barriers and facilitators to implementation at the same time. So that might qualify as an integrative synthesis as well. But you might find a reviewer of a journal who doesn't like that use of the term and thinks it should really be reserved for qualitative and quantitative. Okay. And please do jump in. As Jane mentioned, we would like to keep this sort of fairly interactive, so please do feel free to jump in with any comments or questions.
So it might be good, Tim, just to, because you've gone over a lot of content, and I'm just we might just hit pause for a moment and have a bit of a discussion. So have you got any questions or comments for Tim in terms of where he's gone in terms of providing you with an overview of some of the definitions and some of the thinking around different types of reviews? How many people in the room have done a systematic review? Okay, so quite a few. So what was it? Perhaps we'll just go around and tell us a bit about your review. So what type of review was it? Was it a systematic or was it an integrative review? So we'll start with you, Donna.
As I've said, I've done 20 Cochrane reviews and
yep.
5 other reviews, so they cover a vast number of areas.
So the 5 other reviews, what type of methodology?
They're again meta-analytic, but looking at non-interventionist types of studies. So the one in particular that I'm involved in at the moment is looking at synthesizing epidemiological prognostic and risk data.
Okay. Yeah. Okay, so I might come back to that. Yes. On the back table. So, Janet?
It's a systematic review on an aspect of social network analysis, so looking at brokerage rules.
Okay. So you did, and which guideline did you follow?
So Prisma.
Yeah, okay. And how did you synthesize the?
Took forever. And that thing
What
where
process?
I started with one question, and then I had to narrow it down, and then it broadened out, and I started out just looking at brokerage roles in healthcare, and then it ended up being across all industries.
Yeah.
So yeah,
Yeah.
it's that trying to find out what makes sense.
Yeah. So you're not, do you want to, because Tim and I had this conversation last night.
I mean, I think project creep is such an issue in systematic reviews, and I think, you know, that's why it's so worth spending a lot of time right at the beginning, really nailing down your research questions, and you know, all the queries around time, efficiency, and so on really centre around that. I think if you really tightly nail down your research questions, you know, it's all about, I think, thinking about, you know, what time do you actually have to spend on this, and what would be useful and meaningful to do given that time, and then really defining your research questions so we've got that.
I think that's something that Cochrane's very much gotten right. It's making sure that your protocol is really upfront. There are, you know, some minor issues that you may come across along the way that you may not have addressed when you did your protocol, but it's like a research project.
Yeah.
By having a protocol, that creep doesn't occur, and you ensure that you're not introducing biases along the way.
I think, because I do a lot of work, obviously, with PhD students and with other members of the team, but one of the things, even though we're not doing a Cochrane review, the piece that we actually make sure that it is actually tied with exactly what you've said is actually around the methodology, that we've actually really come to a clear agreement. And then the other thing is that when you read a systematic review, it looks like it just really unfolded very orderly and efficiently. But in my experience is that you really have to invest at the front end, and you actually have to look at the literature to help you frame, you know, to think about the question. So you'd ask the question and then just have a quick look, because you actually may not even be able to answer it. And you have to really start to think about what exactly are you really wanting to answer and what do you need to define, and then to start to be thinking about the search terms. So I think that as you're writing your protocol, it's actually a part and parcel of actually really sort of conversations, having a quick look. It's not actually about doing a detailed search, it's about having a quick look and just really starting to get an understanding of what's potentially possible.
And I think that's one of the things I find challenging, certainly when you come to write up a review, is there's this sort of sleight of hand involved in terms of, you know, your introduction in your manuscript pretends that you know nothing about the literature, when in fact, you know, your review questions and methodology has to be informed by some knowledge of the literature. You know, you can't just start in a vacuum. So there's a bit of it's a bit of gamesmanship.
Yeah, because otherwise I think you can end up, and you know, I think that's what we might have heard from Janet. You know, you can actually end up in the wrong location, or kind of at a bit of a dead end, or suddenly actually feel like you've ended up in the wrong country, or you've really drifted quite far. And so it is actually really quite important. And I know the commission review we're doing at the moment, the piece that the team were really quite anxious because we spent a lot of time up front, didn't we? And we hadn't even started searching, and we were really just kind of mapping it out and really getting the methodology really quite tight in the search terms and checking. And Tim will talk a little bit about that. So I just sort of wondered, that's from my perspective, when you when you're reading these articles, they, of course, just like when you wrote your PhD, it sounded all very beautiful and very smooth, and that's what the reader wants to read. But we don't often write or tell people what's the lived experience about in terms of getting to that point. And then the other important thing, that obviously the day that the review happens, when you do the review, that's kind of the date when you draw a line in the sand, and you don't go back to the literature, and that's when the protocol is actually there's agreement with the team, you've defined it, you're happy with the search terms, you've actually checked it out with the librarian, you've got confirmation, and then you run it, and that's what you're going to write up.
Yeah.
So any other questions for Tim before he moves on?
So we're already up to that.
No, you're okay.
Okay. And of course, feel free to disagree with anything I say as well. I should have said that at the beginning. I'm quite happy with disagreements. But I think Jane makes a really good point about a stitch in time saving 9. It really does. You know, putting that thought in at the beginning will save you all sorts of trouble later on down the track. So there are some kind of, I guess, seminal papers out there around synthesizing quantitative and qualitative research, and I just wanted to cover this briefly, including the Whitmore paper, which is probably the most well cited by nurses. But again, my view, and this is another somewhere else people might disagree with me, I actually think that paper's somewhat obsolete now, because in fact, it didn't really give any specifics around the approach to synthesis, and it was sort of almost like anything goes. You know, you get your qualitative and quantitative and you throw them into your big stirring pot and some magical answer comes out. And I think in some ways that's actually been used as a you know, validation by publication for sloppy methods in some cases. The Cochrane group and principally POPAY have been really instrumental in trying to put some rigor around this narrative approach to synthesis, and particularly narrative synthesis that incorporates both qualitative and quantitative. And I really think that that really is now the Bible, if there is one, for narrative synthesis, and it's principally available in a form of a report, which is available on the website at University of York. And you don't just download it; you have to actually email them for permission to download, so they can keep track on who's using it. But I would really encourage you to get that full report. There are snippets of that available in various journal articles, but I think that full report is actually very, very helpful. Okay. Just very briefly, this again is the Cochrane collaboration, and they identify 5 roles for using qualitative evidence when you're principally looking at quantitative results and quantitative results around effectiveness. Because remember, that's really Cochrane's still main game, although Donna's mentioned that they also do other kinds of reviews as well. But the important thing to note here is that in all cases, you synthesize the qualitative separately from the quantitative in the first instance, and then you try to integrate the findings, the 2 syntheses, if you like, later on down the track. So there are no approaches that I know of where you actually start right from the word go with both qualitative and quantitative, trying to integrate those. Those methods may be coming, but currently I think it just makes life much easier if you... and of course, what that raises to me is a question of when you come to publish, sometimes it's actually much easier to publish your quantitative review and your qualitative review. And you need to think quite carefully about that, particularly, of course, for people with an academic role where, you know, the key metric is number of publications, unfortunately. It's very tempting to do that. Sometimes, of course, the real value of an integrative synthesis is that it does combine both qualitative and quantitative. And if you present them separately, you actually lose the really important finding from your review. But sometimes it actually makes sense. And I think while Jane talked about, you know, making a plan, a good plan to start with, there are some things like that that you can actually make up your mind about later on, and just wait and see. You know, does the qualitative literature actually, are there key messages from that you could present separately, or does it only fit together? Ben?
I think space is sometimes another reason that you might want to publish separately. I think even though there are more general reviews, often it's hard to fit it in trying to combine quant and qual. That makes it even more.
Yeah, absolutely. So for Newcastle folk, that was just a comment by Ben that journal space is an issue when you're trying to cover a huge amount of literature, particularly, and remember it's really the diversity of literature that uses that word count. It's not the number of studies. So you might have, 100 studies that are all drug A versus drug B in the same population that you can fit very nicely into a BMJ article of 3,000 words. Whereas you might just have a 20-article review, but it's totally heterogeneous, with qualitative and quantitative and descriptive and evaluative, and it's a complete nightmare to try to get that into a journal article. And the only suggestion I can make there is, apart from trying to parcel it into portions that make sense, and they have to make sense, they can't really just be for convenience, is to go for a journal that really allows supplementary online material as well, and then you can put lots and lots of detail outside of the word count. Now, a caveat to the sort of what I've just said about not making arbitrary cuts. Unfortunately, the way that the academic literature works is that there are some arbitrary cuts that seem to be perfectly acceptable, and that reviewers will rarely question. And those are around, for example, the distinction between quantitative and qualitative literature. You'll rarely find a journal reviewer has a problem with you making that division. Although some people might say, well, that's totally arbitrary. They're all about the same topic. They're informing the same research questions. Why shouldn't, surely you should include them all together. But the current status is nobody will query it if you say, well, this is the quantitative review, that was the qualitative. Similarly, you might split by disease type. And again, if you're looking, for example, as we often do, around issues in self-management in chronic illness, why would you want to divide by disease type? That doesn't make sense. The issues actually are very similar across many of the disease types. But again, if you're submitting to a renal journal or a heart failure journal, they're not going to question if you've just focused on one particular disease type. So these are sort of tricks of the trade, I guess, which I'm not necessarily encouraging because I don't necessarily believe in the veracity of them. But if you're faced with a situation where you just cannot get it into one journal article, there are options available to you, I think.
I was thinking, Tim, and you might like to talk about Claudia's review.
Yes.
We actually did a review on what patients and families think is most important when the patient is dying in our acute care hospitals. It's a very hot topic. But when we went to the literature, it was massive and just absolutely massive. There had been so much published, and we had to go back for 25 years because the first seminal paper around what patients want and families want at the end of life was published 25 years ago. And that was a really hard decision, but we had to decide. The only way we could manage it was to divide, and we analysed the quantitative literature first of all, and that has been published, and then we analysed the qualitative. I guess what's actually interesting in that review was that the same themes came out in the qualitative, but there were some additional themes, and that really gave voice. You really got the patients' and families' voice in the qualitative review. But ideally, it would have been great just to have done one, but we would never have. It was just going to be too massive.
I mean, I think the ideal is that you would actually divide by research question rather than any of the other things, methodology or disease group or whatever, but that you don't always have that luxury, of having. But again, some forethought and a few pilot searches to just find out how much and how diverse the literature is likely to be that's pertinent to a particular research question will put you in a position to make those decisions around that. Okay, so narrative synthesis. These are the stages or the main elements that Cochrane team have spelled out. And this is based on a systematic review they did of the various approaches that have been taken to narrative synthesis. And note that they divide effectiveness reviews with implementation reviews as well, which of course is especially pertinent to today, where we're really focused on the implementation aspects. Now, the first thing to say is that those are not mutually exclusive, and you can by all means have a review where you do look at effectiveness and also aspects around implementation. But I think, again, you know, that's probably a type of review where you are going to have challenges squeezing that into one journal article. The other thing is to mention that while these are for narrative synthesis, in fact, I think these elements actually apply to any kind of synthesis, be it a meta-analysis or a meta-synthesis as well. I won't go through this in great detail because we're short on time, and this is available to you in that report that I mentioned that's on the web. But I think it's really worth noting that many published syntheses, and I read systematic review after systematic review, where they really stop at the second stage, where all they've really done, and I return to that analogy I made about qualitative analysis, they've basically got to the coding stage in the same way that actually many qualitative research papers you read do, without really pushing all the way through to that final thematic analysis stage, where they've really brought a rich interpretation to that initial coding in terms of what that means for clinical practice and policy. So you often end up with this very sort of unsatisfactory, superficial, kind of descriptive analysis, where it kind of reads like a shopping list. You know, well, there were 20 studies and 5 of them were with this group and 6 of them used that kind of method. And then you kind of left feeling, well, so what? You know, what does that tell me actually about what I can do with my patients at the end of the day? The other thing that I find really interesting is just that while I mentioned the checklist for metasynthesis, the on-track, actually doesn't require syntheses to have a limitations section. And I find that amazing because I think, you know, all literature reviews have limitations, and it's really important that you're transparent about that and reflective on the scope of your review to inform future efforts. Okay, again, I won't focus on these in any detail, but these are some of the tools and techniques that POPAY and colleagues identify for that first stage, or rather the second stage of synthesis after you've developed a theoretical model. These essentially are just ways of comparing and contrasting studies. And they're probably things that you would use whether or not you knew about this framework. But, you know, I guess what this does is gives you a nice terminology and methodologies to validate what you're probably doing already. And I think, you know, tabulation probably is the principle among these. I can't think of a synthesis that you would do where you wouldn't use putting things into tables. You know, that's a kind of, unless you're an incredibly qualitative type of person that sort of thinks in a much more visual way, or I think most of us probably like to see things in tables. It makes us feel better, apart from anything else, that we're making progress as we go. One interesting point to make here is around vote counting, and I don't know, Donna might like to chip in here, because one of the things it says in the Cochrane handbook is not to use vote counting. So that's where you say, we had 10 studies, 6 of them showed there was drug A was better than drug B, 3 of them showed there was no difference, and 1 of them was the other way around. Of course, what that doesn't do is tell you anything about the quality of those studies. So it may be all the good quality studies showed an effect and the bad quality didn't. You know, the size of the samples, anything to do with the differences between the interventions and the populations and so forth. So that's something to be careful with. However, you do read time and time again, you do see that sort of vote counting. So it's just something to approach with a little bit of caution. Do you want to make comments
to that? I'm very anti-vote counting. Yeah. For example, the powering individual trials might be limited, so if it's a negative finding, it's not necessarily because it's a negative finding, it's the sample size is very small. Alternatively, you could, as you know, you've got the file draw problem where you are far more likely to find positive results reported, and people will often push something over the 0.05, you know, 0.051, and therefore count it as significant, but how does that translate to clinical relevance? Yeah, so absolutely not.
Absolutely. Yeah. And of course, the issues that John has just highlighted there are really things that meta-analysis is really helpful in overcoming. So, the whole point of meta-analysis is that it increases power because you're essentially combining sample sizes, and it weights the results according to how big the samples were. You can do subgroup analysis based on the quality of the study and so forth. So, and you can also look at publication bias in a formal way. Narrative synthesis, those issues are not quite so easy to deal with, which is why people often do fall back on vote counting. But I think, to some extent, I think if you had 100 studies and 95 of them were pointing in one direction and 5 of them weren't, I think probably it would be very difficult not to point that out at some stage as being, informative. But I think where you've got smaller numbers, I think, you need to be very careful, and where there's big differences between the studies. So these are just tools and techniques for exploring relationships, which is that third stage of synthesis, where you're really starting to use subgroup analyses. And this is where you're really starting to get into that qualitative part of the synthesis. And that's even if you're doing a meta-analysis. There's still likely to be, unless you get a really nice, clear, strong result from the meta-analysis, very often you'll get heterogeneity, you'll get mixed results, and that's where this latter part of the synthesis really comes to the fore and really becomes very qualitative about unraveling that heterogeneity. Why are you getting mixed results? What is it about some of the studies that differed? And can you come up with plausible explanations for that and hypotheses that you can test through subgroup analyses and future research? Just pause again for anybody to interject. Has anybody had, has people had experience of this type of thing, or would they like to contribute from their own experience? We've obviously got a wealth of experience in the room. Yeah.
Tim, I just want to go back to one of the points when you sort of finished off about vote counting. You said something like 95. You had 95 studies and the majority were showing a point. So you just want to talk to the way in which you think about the study design and the quality of the evidence?
Yeah. So obviously there are formal ways of evaluating the quality of the studies. That's very easy if you're dealing with one particular design, and the classic example is randomized control trials, where you can use the Cochrane bias tool, or in fact there are numerous other published tools that you can use. It gets a little bit harder where you're dealing with a lot of very different designs and methods, and you have to actually say something about the quality overall. I like the American tool for that, which is the Health Research Quality tool. And the reason I like that, which again is freely available on the internet, the reason I like that is because it can cope with studies of any design, and it also, not only do you rate internal validity, so that is the sort of the strength of the design, and in terms of whether comparing group A with group B was really valid based on the sample, how the samples differed and so forth. But it also, you can rate external validity as well. So that is, how does it actually, how relevant are the findings to the particular healthcare system that you're working with? And again, for the purposes of today, in terms of implementation science, I think that's really critical. So that's a really, really useful tool. And the interesting thing with that tool is you can potentially have a randomized control trial that actually gets rated as poorer quality than a non-randomized trial if that non-randomized trial has good controls in place in other ways. Because I think sometimes we get sort of glossy-eyed over randomized control trials, and just seeing that word randomized is enough to sort of cover a multitude of sins. And of course that's not actually the case. I mean, there's a lot of caveats to that. So I like that tool. Again, there are tools for rating all sorts of qualities, all types of design. So there are tools for descriptive quantitative studies, there are tools for qualitative studies, although they're controversial, and we'll touch on that later. I think it's really about choosing rating scales that you're comfortable with. Jane's nodding, so I think maybe I'm not answering the question.
No, you are, and you're going to talk about that. I can see that.
Okay, okay.
So that's a good thing.
Yeah, okay. So have people had, maybe that's a good point to stop there as well, is have people had experience with particular quality rating checklists that they found really useful, or ones that they didn't get on with and so they actually had to get rid of and choose another one? Because these are the kinds of things, where we can all benefit from each other's experience. Not that, because somebody else has not found a tool useful doesn't mean that you wouldn't. We have different preferences, and also it depends, of course, on the literature that you're dealing with. But, yeah. Okay. Just a quick word about use of theory. And feel free to stop me as well, James, I know I'm going way over. So I think at some stage it's often very, very useful to bring some sort of theoretical lens in, particularly when you're dealing with these messy issues around implementation, barriers, facilitators, and so forth. The question really is, at what point do you bring that in? So is it right at the very beginning, in terms of how you define your research questions and your inclusion criteria and your approach to synthesis? And you will have seen that POPAY recommend that people do think about choosing a theoretical model for that. And that's very, very useful, particularly when you're dealing with complex interventions, because one of the real risks of project creep with that type of intervention is not clearly enough defining the intervention that you're talking about. And I've had multiple experiences of that. One review we did together, Jane, which was around the impact of community palliative care nursing packages in helping people to die at home. Okay, so our outcome was whether or not people died at home, yes or no, and the intervention was some sort of palliative care community package. Now, of course, that sounds all well and good and easy when you say it like that, but when you start to look in the literature, exactly how you define a palliative care community nursing package actually really fraught with difficulty. So starting off thinking about what's in, what's out, why it's in and out, and therefore, and therefore you're already starting to hypothesize potential mechanisms for why you think various components of that intervention would help people to die at home. I think that's really, really useful early on.
Just alternately, and we've done reviews with really complex interventions like that. But a real strength of systematic reviews is actually drawing together those models that may come under that umbrella term, or terms that also describe a similar intervention. And what you find is that you get a sense of the different components that inform that, that program. And that in itself is a hugely useful step. And then you can start to pull apart the effectiveness of each of those components of the program.
Yeah, I absolutely agree. And I think it depends on the current state of the literature on the particular topics that you're reviewing. If there really hasn't been another review done previously, often it's good. You may be the lucky person that gets to really review very, very broadly and just gets that initial idea of the signal versus noise ratio. Is there a clear signal coming in when you look really broadly across the literature that yes, there is an intervention effect, even given all this heterogeneity, these differences between the different components. But of course, the reality is usually what you'll find is there's just a tremendous amount of noise when you do that. And then what you'll really do is you have sort of, you being the one that's sort of laying down for others to sort of walk over on their way to then unraveling that narrative in future reviews. Really starting to make, and what you probably would end up doing in a broad review like that is making hypotheses about what could be the cause of this heterogeneity and the difference in the results that you're getting. that would both prompt somebody else to do another systematic review looking at a smaller subgroup defined by those variables, and also, of course, more primary studies that test those hypotheses as well. So you'd be very brave to do that, but
I was just going to say, just on the point of using theory and trying to consolidate it, some experiences I've had before has been around coding interventions according to, say, behaviour change techniques. So everything is standardised across all of your studies, which is a really useful thing to be able to do. But often you find that the level of reporting of the interventions is so different that you have to go either back to the studies or you have to kind of break them on kind of limited, they're limited in different ways, so they're not fairly representative, because for one study you might have to provide with a massive additional file and you can code every behaviour change technique that you can see, versus another study that you know there's probably loads in there but they haven't reported all of the information. So if you're then trying to understand the impact of each behaviour change technique, you kind of not getting the full picture. So
absolutely, absolutely. And I've worked on, it sounds like a very similar review.
could you just repeat that question?
Yes. Oh, so this microphone's not working. Oh, okay.
Is it switched on? Yeah.
It says on.
If you can repeat it, I'll just see without shutting the whole system down.
Otherwise it's picked up everybody else, and I just think that was too far.
Okay. Okay, so the point really made was that, you know, my statement was really all well and good in principle, but in fact, some types of intervention, particularly complex behavioral interventions, what you tend to find is that if you use some sort of theoretical framework to try to classify those, you find that the literature is not adequate. The reporting is not adequate to enable you to do that. So authors very seldomly have given you sufficient detail to enable you to really classify the key elements in behavioral terms. And we've had experience of that where we looked at patient education for cancer pain, self-management, and we used Susan Mickey's behavioral change framework for that. And we found that it was, you know, it was useful. It went some of the way, and we did get sort of something of a signal in terms of interventions that used more than one behavioral change component tended to be more effective than those that used only one behavioral change component, which was encouraging. But there was still a huge amount of noise, and a large part of that was due to all these unknown variables, you know, because the authors just didn't give us all the details. So it's a very frustrating exercise. I don't know if you found that, Natalie. You have to make a call, you know, well, you kind of think, well, I don't really know, but I'm going to put this intervention in this basket versus this basket because it looks more like that kind of intervention than that one. So it is very frustrating. Of course, you can write to the authors and ask them for more information, but I'm always amazed at how low the response rate is. I mean, I don't know about you, but if I'd invested, you know, years of my life in a randomized control trial of a complex intervention, I'd be delighted if somebody showed an interest and was reviewing. That actually isn't the case. I mean, I routinely find, you know, only about 20% of people actually reply to your emails. Of course, some people have moved on, they're not at the same institution, etc. But still, I find that very strange and a little bit worrying. It rings alarm bells to me, but, you know, anyway.
I sort of feel like I want to put an advert in at this point, so we'll do. For all of you doing research, and you're all doing it, what Tim is talking about really speaks to why it's important that when we write a paper, and if we write a protocol paper, we actually describe the elements in the black box. Because the clearer that we can define what we've done in our intervention, the better it is for everybody. People don't replicate the same mistakes, but they also take on the elements that were really helpful. And also, too, we will have better reviews. Whatever type of review, we'll have much better quality evidence that we'll be able to generate. So I think each and every one of us in the room who is conducting research has a responsibility to write the protocol paper and to make sure that we're as clear as possible with regards to the
And I think really part of that is just that we're in this sort of transitionary period, unfortunately, where, you know, the era of evidence-based medicine has not quite lived up to expectations in terms of giving us clear answers about treatment A works, treatment B does not work. Well, in fact, the answer is usually much more complicated than that, and it means, you know, the answer really is that, well, treatment A works some of the time for some of the people in certain contexts. And now we have to unravel that heterogeneity. And unfortunately, the literature is a little bit slow in catching up with that. And that's why there are checklists like the TIDIA checklist, which I mentioned right at the beginning, that are really trying to encourage authors to report. And that's a very simple checklist. It basically, you know, asks the questions: who delivered it, when did they deliver it, how often did they deliver it, you know, why did they deliver it in terms of the rationale. You know, it's a very, very simple taxonomy. And it would be enormously helpful if people really started to report their interventions that way. Okay, so meta-analysis, just briefly. So it's the statistical approach to synthesis, and essentially talking about comparing groups in terms of, you know, the direction of difference, the size of that difference, and the consistency, as we mentioned. And very often, consistency is not 100%. And the nice thing about meta-analysis, of course, is it spits out a nice little diagram like this. And this is actually the meta-analysis that came from the review I mentioned about community palliative care for helping people die at home. And this is a rare example where we actually did get a very strong, you know, signal, really. You know, with the exception of these 3 studies on higher up on the graph, where their confidence intervals did cross the no effect line, we got a pretty strong signal that actually community care, home care, did actually help people die at home. Now, and it's a nice visual forest plot, as it's called. And it's called a forest plot because if they line up in a certain way, it looks a bit like a tree. I think that's why it's called a forest plot, yeah. Now, that's what I like to think anyway. Now, compared with primary studies, now meta-analysis, as we've mentioned, they can potentially increase power. They can improve the precision, because obviously when you increase sample size, then you narrow your confidence intervals usually. You can sometimes answer questions that weren't posed by the individual studies themselves, but you have to be a little bit careful with that. And that's always a limitation if you do choose to take that approach. Taking data that was intended for one purpose and using it for another, you know, review is, you know, is something you need to be very careful and very explicit about, that that's what you've done. Particularly when you come to rate the quality of the findings in terms of the purpose to which you're putting them. Because that primary author may very well get quite upset when you say, well, yours was a low-quality study for the purposes we put the data, when in fact it was a very high-quality study for the purposes of the data was actually intended for. So that's those are decisions that you have to make, and care needs to be taken. And as we've mentioned as well, it can sometimes help to clarify the heterogeneity issue, or at least generate new hypotheses, because then that's when you get into that subgroup analysis. So you may start, for example, to do subgroup analysis on high-quality studies only, rather than all the studies. Or you may choose to define the studies in terms of particular components of the intervention and do subgroup analyses on those. Now, the big cautionary note to all of this is that meta-analysis is only possible where a group of studies is considered sufficiently homogeneous in terms of the participants, the interventions, and the outcomes. In other words, are you really comparing apples with apples or oranges with oranges? Now, of course, that's all well and good when you've got a nice, you're looking at randomized control trials of, you know, paracetamol versus some other analgesic. And you're looking at that in a very, very, you know, homogeneous patient population. And of course, that's what many RCTs, particularly those sponsored by pharma, do. You know, they actually define the population very, very precisely. They throw out anybody who actually has comorbidities or doesn't quite fit the mold. which will give them the chance of maximising the chance of finding an effect. Now, of course, when we're dealing with implementation science, we're dealing with complex interventions, we're dealing with real-world practice, we actually want people with comorbidities, we want the complex cases in there. And therefore, the chances of actually being able to do a meta-analysis probably reduce. Having said that, you know, this really is a sort of how long is the piece of string thing. And sometimes it surprised, I mean, I've actually been very, very surprised by one of the reviews I've worked on, which was a meta-analysis of quality of life outcomes for people with cancer from culturally and linguistically diverse backgrounds. We actually did a meta-analysis, believe it or not, of people from culturally and linguistically diverse backgrounds in terms of quality of life outcomes. So not only do we have huge heterogeneity in terms of obviously what's culturally and linguistically diverse, but also the way that quality of life was assessed. We had about, I don't know, 10 different measures for that. Now that paper was published in the Lancet Oncology. So after having been rejected, I should say, by 5 other journals on the way. So, go figure. I mean, if that had been sent to me to review, I would have said that a meta-analysis was inappropriate to that. However, the team made a decision that we should do a meta-analysis, and it was published. So I think, what we did, I should sort of, regain some credibility following that statement. In terms, I think that review, what it did do was, we were then able to go. So surprise, surprise, we didn't find, an overall effect. But we then did try to do some subgroup analyses which more sensibly defined smaller culturally and linguistically diverse populations. And we did then actually start to see an effect, for example, for the Hispanic population in America. So I think, whether an overall meta-analysis is appropriate is a separate question from whether it may be possible to do some meta-analyses focused on particular clusters of studies. So you may find that you've got a very, very diverse selection of studies that focus on, for example, patient education, but you've got a small subgroup which focus actually using a very similar technique to that. So you are able to do a meta-analysis just on that small number of studies, but not on all of them. And that's certainly an approach we've taken in some of the systematic reviews we did. For example, one of advanced care planning in end-stage kidney disease, where there were a subgroup that used a particular approach. Just quickly, these are the types of statistics you might use in meta-analysis. When I've done meta-analysis, I've used the COCHRANE software, which is called Review Manager, or RevMan for short. It's incredibly easy to use, and I think it's probably a bit too easy to use. It's a bit like SPSS, where you actually don't need much statistical literacy to use it. And you can just sort of throw the data in, and it spits out the answer and draws you a nice forest plots and everything. So I would encourage you to, if you are going to do that, and you're not very statistically high statistical knowledge, that you engage a statistician on your team. You will need some statistical method for looking at heterogeneity.
Oh, sorry. No,
yeah.
just a lot of statisticians aren't really aware of meta-analytic techniques. It may be improving with more recent graduates, but it would have to be someone who understands meta-analysis.
Yeah. So for the Newcastle people, that was just a comment from Donna with experience in Cochrane reviews that a lot of statisticians actually are not that familiar with meta-analyses techniques. I have to say, some of the statisticians I've talked to as well don't like them because they consider them very boring as well. So there's probably, maybe a bit of both. So you'll need some statistical method for dealing with heterogeneity usually. And again, this is a sort of, people tend to just use a random effects model and say, well, I've dealt with the heterogeneity. But actually, of course, it's much more complex than that. But you would rarely get, perhaps in some reviews that are dealing with a very, very simple drug trials, you will get fixed effects, but very often they'll use random effects because they expect some heterogeneity. And you'll also use some sort of heterogeneity estimate. And Cochrane favours this I-squared statistic, and they give guidelines for the sort of brackets of results whereby, for example, 0.5, above 0.5 is, I think, substantial heterogeneity. Above 0.7 is considerable heterogeneity. So sort of, i.e. really you start to question whether a meta-analysis was appropriate once you get up to the sort of 70.7 mark. We've already mentioned effect summary in terms of forest plot. Donham started today's session talking about bias. The most common type of bias to look at is publication bias, and often that's done via a funnel plot. And this little diagram here is an example of a funnel plot, where you just look at plot the size of the study against the treatment effect. And what you tend to find, of course, is that the bigger studies, therefore the ones giving a narrower effect estimate, cluster together, and then you start to get more noise as you get the smaller studies. And that's quite encouraging if you see that. If you don't see that, you know, that's a bit of a worry. Okay. Okay. Okay.
Yeah, I think so. Are people happy for Tim to keep going? Because he's going to speak now around metasynthesis, which I think is interesting.
Just briefly.
Well, just see if Newcastle wants to say
Yeah,
anything on
good
what
idea.
first, and then
Great.
Okay, Mel, do you have any questions in Newcastle? Seem to be talking among themselves.
Just down the bottom.
No, their microphone's on. Mel, can you hear me?
Yeah.
Do you have any questions in Newcastle?
No questions.
No questions. Okay.
No questions in the whole of Newcastle.
we'll break the volume so you have to talk.
Tim, do you know how?
Okay, so just briefly, metasynthesis. Has anyone done a metasynthesis or is thinking about doing one or some way through?
Well, I was involved in one. We set out to do a systematic review of disability research in Australia, but in the end we weren't really able to, because the studies were so heterogeneous, so few RCTs, so we can't like
Okay, so that was somebody who has experience of a metasynthesis in disability research. Yeah. Okay, so metasynthesis just refers to synthesis of results from qualitative studies. And the really, really key thing I want to emphasize around this is it almost the direct opposite of a meta-analysis. A meta-analysis is all about trying to summarize statistically results from primary studies to get a more precise answer or summary of those results. In fact, a synthesis, metasynthesis of qualitative research is interpretive rather than aggregative. That is, you're actually trying to breathe new meaning and interpretation into results from qualitative studies, not merely just to aggregate them. That's not to say that you don't start by aggregating them. And again, so the synthesis approach in a metasynthesis really is directly analogous to qualitative analysis. So basically, rather than using interview data, you're using the results of qualitative studies as your data. But otherwise, the process is really, really very similar. And in the same way, in a qualitative project, you move from coding to thematic analysis. You do exactly the same thing with a metasynthesis. Now, when you do that, a really key question you need to ask yourself is, well, whose voice is actually loudest in terms of what's coming through in your interpretation? Because remember, when you're analysing the results from primary studies, you cannot remove the primary author's voice from your data, okay? Even if they're reporting lots of primary data in the form of patient quotes, for example, they have still chosen which of those quotes they will include in their paper. In fact, they've often cherry-picked them, you know, to illustrate their key themes. And sometimes I'm actually amazed by how badly the quotes illustrate the key themes. And you think, here's an author who's basically made up their mind what they want to say, and then they've tried their best to choose quotes that illustrate that. So you cannot remove the author. The only way to do that is to actually focus only on the to any large extent, is to focus on the primary data. And again, we've got an example of that, where we chose to do that. We actually chose to analyze only the raw data. But even then, you'll still only have access to the raw data that the authors have chosen. What we hope to go on to do is then to analyze the results from the authors more broadly and compare the two sort of in a blinded fashion and see if we actually end up with the same answer or very different answers, very different synthesis results. And that will be really interesting, methodologically speaking. And I think this problem is only going to get extended when you think about these, now we're getting overviews, that is reviews of reviews, where, you know, then the overview only actually has the voice of the previous reviewers, who are really only voicing the views of the authors, who are representing the views of the patients. And, you know, you start to question actually to what extent are we really representing the voice of patients at all in all of this, which is unfortunate because, of course, that really is the raison d'etre of qualitative research, is to give a voice to people who wouldn't otherwise have a voice. And I don't think, you know, senior clinicians and academics who publish in journals really fall in the vulnerable category of people who don't have a voice. So you know, I think it's an issue to be aware of. So there are various approaches to metasynthesis. I probably won't go into detail with these. We can circulate some good reading for you afterwards if you're interested. But essentially, I think the approach that most people use has become very popular is just this thematic synthesis, which is really kind of analogous to that bog standard qualitative thematic analysis that you see in, especially in the high-flying medical journals, you know, where they're not too bothered about the real sort of, the nuanced qualitative methodology. They just want to think about thematic analysis or a framework analysis type of approach. So it's relatively easy and relatively quick to do, but metasynthesis is incredibly time consuming. So metasynthesis is not without its controversies within the qualitative research community, starting right from the question of really, whether should we be doing them at all, particularly when you're trying to combine studies that have used different qualitative approaches and are grounded in different epistemologies. You know, can we really actually combine those in meaningful ways? The other key question is whether we should appraise the quality of primary studies. Some qualitative researchers are very, very, feel that certain methodologies can only be reviewed by people with a high level of expertise in those methodologies. So that's an issue. And then, of course, there's this issue around generalizability. And, of course, generalizability is an issue in qualitative research in terms of primary studies. And it's a moot point whether that generalizability is extended when you start to combine more than one qualitative research project, or whether, in fact, that issue of generalizability stays the same. And somebody in 2007 said, well, it's unlikely there's a standardized set of procedures will be developed for qualitative metasynthesis. And I think that's probably still true today, nearly 10 years later, despite the fact that we now have a tool for rating the quality metasyntheses, that on-track tool which I mentioned. Okay, and then I just wanted to just briefly mention rapid reviews, which is the kind of review that Jane and I are currently working on, she mentioned, which is a huge review across a wide range of topics that's been commissioned. Rapid reviews are really just reviews where you cut corners a bit. So they're still systematic in some sense, but you're acknowledging that you are making compromises on some aspects of rigor in return for timely completion and in favour of informing the policy and the clinical field in very practical sense. And of course, what that means is that you have to, as the author of a review like that, you have to very carefully balance the impact of each and every shortcut you're taking. So examples of shortcuts you might consider are things like whether you really need 2 people to do inclusion, exclusion, or whether you might just double code a random 10%, for example, of the include-exclude. And if you get fairly good inter-rater reliability, then you can probably just go and rate the rest with 1 person only. You know, same thing with data extraction, whether you can extract data with only 1 person, provided you use an electronic pro forma. So those are the kinds of decisions you can make. And in fact, there's been a little bit of work to look at whether this makes a big difference. One in particular where they compared 7 rapid reviews with systematic reviews that have been conducted on the same topic. And they found that they did actually yield similar results, except that the rapid reviews were narrower in scope. And I think that that's a key issue as well. When you're undertaking a rapid review, that's really where you really need to keep your research question so tightly focused. That's the way to do a review quickly. Really keep it very, very closely confined. Okay. So, and I'd just like to finish with that because a PhD student at a recent workshop series likened her experience of doing a systematic review to poor old Alice falling down the rabbit hole. And it was amazing how these original illustrations, you know, which were done all that time ago, fitted so beautifully, including, you know, the playing cards, which could be the sort of the journal articles overwhelming poor Alice. But the one I really liked was where she talked about visiting her PhD supervisor, who of course was the caterpillar sitting on the mushroom smoking a hookah, which I thought was really, really nice. So it was the particular supervisor actually who fitted that beautifully. But anyway, and it wasn't Jane.
Thank you very much, Tim, and thanks for allowing Tim that time, because I think it's actually was really helpful for him, for Tim to be allowed to, you know, take you on that journey in terms of just a really good overview of different approaches to various systematic reviews. So we have deviated a little bit from the plan, but we'll get back on track. So I think what we're going to do now is break probably 10 15 minutes for...
well, she finished the talk, I think, maybe. Philip is talking.
Yeah, Philip is talking quite briefly. If everybody's happy for that, that would probably work well.
Then we can grab a coffee.
And then we can break for the groups. Okay, sorry.
But I'm thinking, Jane, if we finish, you know, if we wrap like kind of, if we into the group work like 5 to 11 or so, that still gives us 40 minutes.
Yep, that's fine. Heaps. Yep. No, because I don't want to disconnect. Sorry, I feel quite responsible. I don't want to disconnect Newcastle. So while we're waiting, I'll introduce Philippa. So I mentioned before, Philippa has worked extensively in cancer care and previously worked for the Cancer Institute and is now doing her PhD. And I've asked Philippa to really, I said to her, I really want you to tell the warts and all story. So Philippa's actually been very courageous to come and present. And she's not going to focus on her topic, which is looking at family meetings and palliative care, but more more around some of the issues that she had to manage in terms of getting this final product. So if you can join in welcoming Philippa. Have you got it?
Yes, 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 yes. I take this microphone's not working, just stand here. Yeah? Yeah, great. Okay, good morning everybody. Good morning Newcastle. I hope you can hear me. My topic's lessons from the field, an overview of the lessons learnt from undertaking a recent systematic review on family meetings in palliative care. So as Jane said, I will focus on the how-to and what I learnt, but I will use my systematic review for the examples to sort of demonstrate the key points. So just to describe what a systematic review is, it ensures that the literature review is conducted in a systematic way and with the same degree of rigour expected of all research. And the first lesson I learned was how to actually conduct a systematic review, because when I started I didn't have a clue. So I just researched. I found some really good articles from Joanne Briggs actually from years ago that I'd filed, and just got an understanding of what the key processes were. And the 6 major processes, and the discussion already will allude to some of these things I'm going to talk about. So the first one was to identify the clinical problem, then to define the aim of the review, then to define the search questions, and we've already indicated that's really important, then to define the method, the databases, the timeframes, the eligibility, and the search terms. And then to undertake data extraction and assess the quality of studies, and then to synthesise and summarise the findings. So my clinical problem was family meetings and palliative care. And family meetings can be called family conferences or patient-family conferences. And I guess identifying those key terms is really the first step to say, well, these are part of my search terms. So I also decided to have a definition to work to for family meetings, because there are different terms used, but the general construct of a family meeting is it's a single meeting attended by the patient when possible, family members and healthcare providers to discuss the patient's illness, treatment and care. And that was for patients in end-stage disease or life-threatening illnesses. So the next thing to do, the second process, was to define the aim of the systematic review, and it was to determine the evidence that supports the use of family meetings to better address patient and family palliative care needs. Then it was really important to define the search questions, because that was going to guide me in the literature that I was going to be looking for. So I've just given you my search questions there. There was what was the evidence, what was the rationale, what were the processes and components, so the who, what, how, why of family meetings, what were the outcomes or benefits for the participants, and what measures were used to assess the outcomes. And that for me was a really important question, because that's really the evidence that you need. You need to be able to look at outcomes to say, yes, that family meeting has or has not been a benefit or had an impact on the patient or the family. And these questions I subsequently used to report the results of my systematic review. So those questions I then addressed in my discussion section in my manuscript. And that was particularly asked for by one of the reviewers of my article. So I thought that was really interesting. So that's a tip, you know, link up the questions and then report back on those search questions if you're going to do a manuscript. Oh.
Just take the arrow off and click it back. Just move it back onto here.
Ah, I see. Okay, great. The fourth process was to define the method for the review, and I cannot stress how important this part of the process, part of the review is. It's just, if you don't get this right, you're not going to get a decent review done. That was my experience. So firstly, as we've already talked about, I used the PRISMA guidelines to provide the structure for the review. And then it was really important to choose the appropriate databases for the topic. So in my review, I used psychosocial and medical databases and also looked at Cochrane.
but it really will depend on what your subject is. The other thing to do is to define the time frames for the search. So pick a time, and it might be, for me it was relevant, 1980 was relevant because that was about the time that information or manuscripts, papers were first published around palliative care, because palliative care is a relatively new specialty. So it's important to define the time frames, also decide on the language. So I obviously opted for English language, but if you were in a multilingual world, say in Canada, you'd probably include French and English languages. I also need to decide the type of journals to include, so that was peer-reviewed journals, and also the type of studies to be included. So for example, I included RCTs and non-randomised controlled trials and qualitative studies as well. And then it was important to define the exclusions. And so I excluded conference proceedings or guidelines, anything that wasn't empirical data to support the findings of that study. You will find in each of the databases that there's various tabs where you can sort of put in these key elements when you do your search. So you can define English language, you can find what sort of journals you want to look at, you can find the years, and all of that needs to be put in before you start your search in that particular database. And that was something I learnt after I'd done a lot of, I guess, reviewing of literature, but hadn't really defined it in a formal way. Okay. The other thing was to, part of the methodology was to define the eligibility, and I used the PCOS acronym to guide that. So my population was adult inpatients with advanced cancer or other life-limiting conditions. My intervention was a planned or unplanned family meeting, and it needed to include at least the family member and palliative care multidisciplinary team members and or the patient, because I actually included studies that were undertaken in ICU, because palliative care teams were involved in family meetings in that context. My comparison was no meeting. My outcome I didn't define because I didn't really want to determine the outcomes I was looking for. I wanted the literature to provide me with the outcomes of family meetings. That was sort of part of my search. And then this type of studies, which as I said already was RCTs, cohort studies and qualitative studies. Now along those lines you need to develop a template so you can assess the papers. So that's a very busy slide, but you can clearly see I had inclusion criteria and I had exclusion criteria. And that's absolutely, and you need to stick to that rigorously. That's one of my tips. You can't, it's very, as you search the literature, you can sort of go off down rabbit holes and see, oh, that's very interesting, and off you go. You've actually got to keep dragging yourself back to say, this is what needs to be included and this has got to be excluded. Now, we've mentioned search terms previously. Some tips around that. The first one is to use mesh headings where possible and check the mesh headings for each search term proposed. And you won't always get a mesh heading to suit your search terms, so sometimes you have to use keywords. It's really important to define the search terms to reflect the review questions. I use Boolean logic and operators of and or, and I'll show an example in the next slide so that some of this makes sense. And I shorten keywords with an asterisk so I could have multiple endings. So family could be families or familiar. It could be not just family as a singular word. And meetings, of course, meeting singular or plural. If you put an asterisk, it allows for that to happen. So here's an example of my search terms. So you can see there the top 7 search terms were, and I've got to spell out typo there, terminal, are mesh terms, and then I looked at other keywords. So end of life, palliative, because that could be palliative, palliation, terminal could be terminally, and hospice could be plural. And then I combined those terms with or and patient and meeting or conference and family and meeting or conference. So that was one particular set of search terms for, I think, the senile database. But you do need to sometimes look at the mesh terms according to the database, because you may have different mesh terms. So that's another tip. Okay, some more helpful tips. We've already talked about consulting the librarian to discuss your search and what search terms might be relevant. And I found that the librarian at the University of Notre Dame really simplified the systematic research, the systematic review in terms of the search terms. So I had this very complex template in my head, and she really reduced it to the bare, not the bare minimum, but very straightforward, concise search terms. I've already said mesh headings vary according to databases. It's really important that search terms are clearly defined and consistently used. You really need to stick to those search terms. I learnt the hard way to save and print my searches for each database, because you may want to go back or you may want to review what you found. And because the literature changes all the time, if you wait and do that same search in 2 months' time, you'll get a different set of numbers and different literature. So I think that's a really important thing to do. As I already said, be clear and consistent about inclusion criteria for the search process, and don't deviate from that. Don't be tempted to deviate from that. Just stick to those inclusion criteria. The other thing is, of course, don't be surprised to find the same paper multiple times due to multiple databases. So that's just part of your search, and you manage that with the way you collate your studies. That leads me on to the next point, is that to have a systematic way of collating all your references, all your studies that you find. I used EndNote, and I didn't know anything about EndNote, so that was another learning, having to conquer how to use EndNote. But once you do, it's like most things, it's worth the effort. It's a worthwhile tool. So my personal experience is I would recommend it, but it's initially the learning curve is quite steep. The other thing is you need to do this in a timely manner. So if you're going to do a systematic review, and I think we've already talked about this, you really need to make it your main focus. You can't be doing a systematic review, I think, in my personal experience, when you've got other things you might want to be focusing on. You really need to focus on the systematic review and do it in a timely manner without distractions. And that's because the literature changes. So that's why you need to have a very tight time frame to actually do the review, as well as setting your time frame of what papers you're going to include. And I'd also report Jane's recommendation of looking at the literature before you actually start your review. Just have a sense of what's out there, what search terms are used, what papers are there, what keywords are included in those papers that you're interested in, because that gives you some clues about how you're going to set up your search terms. This was my flow chart as a result of my systematic review, so that I found 5,050 papers, and there was one other paper that someone alerted me to. And then I removed the duplicates, which was 2,349, and that left me with a total of 2,702. And then I looked at the title abstracts and excluded them either on the titles, and I've got an example of a title here. And I kept all of my records in folders. So I had the entire number of papers in one folder in EndNote, and then as I went through these processes, I created new folders. So what was screened, what the duplicates were, what titles. I had a folder for screening by titles, a folder of screening by abstracts. So for instance, a really obvious title of a paper that I excluded was Animal Models for HIV Infection and AIDS, Memorandum from a WHO meeting. Now clearly that was not anything to do with no interest to me, but I think meeting was the word that triggered that paper to be included. So I came down to 27 full-text articles which I needed to assess for eligibility, and that's when the data extraction process takes place. And after the data extraction, I ended up with 14, oh, no, I've got the wrong number there, 13 in total. The next process is data extraction and assessment of the data quality. So I used a data collection instrument based on the eligibility criteria to extract the data from the full text articles. So that's a copy of, it's just a template that I developed for my studies. So I had listed the inclusion criteria, I had listed the exclusion criteria, and then whether the study was eligible or not. These were the full text articles. And then I also extracted information about the author, the date of publication, the participants, the aim, design, intervention, results, outcomes and measures, and any other evidence from that paper. So we completed one of those for each of the 27 full text articles. And then on that basis, we got the 13 that were considered eligible using that data extraction. The other thing I did was to use the Cochrane collaboration tool, even though not all my studies were quantitative. There were 10 quantitative and 3 qualitative. But I found that that tool was relatively easy to use, and it assessed the risk of bias in the studies. For instance, if you had incomplete outcome data reported in a study, that was assessed as an attrition bias. And I now move on to what Tim has already alluded to, which was POPAY describing 4 elements for a narrative approach to the synthesis of the data. So the data in the 13 papers I looked at, and I used, for the preliminary synthesis, I used 3 of his techniques, which was textual description, groupings and clusters, and tabulation. And then I also, when I was exploring relationships, which is the next step down, I looked at subgroup analysis. So I'm just going to show you 4 examples for each of these, so you've got some sense of not just the terms, but what it looks like. So this was a textual description, an example for my systematic review. And it was just an overview, really, my summary of what I found and some key elements. And that really formed the summary of my first paragraph of my discussion paper. And as you can see, there was really only one study that demonstrated improvement in family needs using a validated measure. So it's extraordinary, really, that in clinical practice we use family meetings a lot, but I only really found one study that indicated with a validated measure there was a benefit in the palliative care context. This is an example of study grouping. So this is quantitative studies and qualitative studies. So I had 10 quantitative studies, and then I sort of described each of those. So there's 3 pre-post studies. So these pre and post measures, post-family meeting, and the qualitative studies. There were different aspects for those 3. Tabulation is what Tim's already described. Is collating the studies using a summary table and using headings such as study, aim, design, participants. And when you read systematic reviews, you'll find that most of them publish a summary table with these sort of headings, or versions of. This is a tabulation example, actually in a table. So it would have the study year, aim, design. This is just for one study, which was Hannon et al. 2012, published, undertaken in Ireland. And finally, this is a subgroup analysis, which is really looking at relationships and further unpacking the data. So because I had 3 studies that did pre-post measures using the same instrument, I looked at the results of those and tabulated that. And that's the end of my presentation. Thank you.
Thanks, Philippa. You made that sound really quite easy. So any questions for Philippa with regards to just how she managed some of the aspects of her review? I think what Philippa's just very eloquently taken us on a journey of some of the challenges that she had and some of the approaches that she adopted to manage the literature review. And that was actually really going from rookie to kind of, novice to expert.
Yes.
In a period of time. I think the other point, and we're happy to have the conversation with you, but one of the key things that probably I'm really encouraging the people, my team, is to actually use EndNote as a way of actually really just a separate EndNote file for managing our systematic reviews. And we don't use that file for any of the writing of the reference. We don't use it as a reference source. We actually just use it to manage the data. And in actual fact, Nicole's probably the person I would consider in the room, or in my team, probably one of the experts in terms of the methodology around the way in which we've done that. But that's actually really quite critically important, because you do not want that file to corrupt, which EndNote files can often do. I think the other point that I just want to highlight that Philippa made, because I think from memory you had a bit of a break in terms of starting your systematic review, and that's when you had to come back and sort of rerun it because it was an unplanned, unscheduled interruption that, and so we had to rerun the review, and having not saved the searches, and that's another really important thing. And they're all tips that you can learn from the librarian. So we...
A really naive question.
Yeah, sure.
In relation to the billion terms, which you've obviously got twice as many studies as you actually have. I'm just wondering if you'd said family and meeting instead of family or meeting, would that not have been more defined? Or why? What about the ends and the ors?
I wanted the family in front of the meeting to describe the meeting, because I want to be a family meeting. So that's why I rather than all.
So you didn't put family or meeting?
No, family, yes.
Okay, thank you. I was just wondering.
Yes. So, yes.
Just another question.
So, do you just mind speaking up for Newcastle?
Sorry.
Yeah.
When you were talking about there was one study that was identified serendipitously in Canada. What would your advice be if you get into the reviews and you've got research terms locked and had a sort of a look at the literature, so you think you know what keywords might be and all that sort of stuff, and then you run your search and you start finding others, other papers that research may not have picked up. Would you stop, go back and do it again?
Well, I guess there's probably different approaches. Tim's nodding his head. So what do you want to say, Tim? He's probably going to send you back to do it again.
That Medline is a very, very strange animal, and it's just, it never ceases to amaze me how you can have all your search terms so carefully worked out, run them, look through your results, and then you'll do a quick Google and you'll find a study that is absolutely what you want, but is not. Which is why I would always recommend doing those extra Google Scholar searches. Asking a content expert if you know one, if you've missed, whether you've missed any of your studies in that area. I think that's really, really important. And I can only put it down to sort of the quirks of the way that the articles have been indexed in Medline. Because remember, these have all been manually indexed by somebody who has a particular perspective and made decisions about the way an article should be indexed, and it doesn't necessarily correlate with the way that you see it, and they're not necessarily content experts working in that field. So the other thing to do, of course, is to look at the mesh terms, find some really relevant articles and look at the mesh terms that have been used to index those as well.
I guess my concern if that was happening was really how good your search strategy was, and I guess I see that as a bit of a amber to red flag to actually probably just pause and sort of reflect and have you actually really got the right search term. I think the other thing is that if you find these articles later, but you have to remember about the inclusion, the date that you stopped, is that you can always add it that you found it through pan searching. So there's other ways of which you can manage it. Or if the field has actually just changed so rapidly, and I think sometimes we're working in an area that is evolving really quite rapidly, and you know, another seminal piece of work might come out. And Donnie, you want to say something?
Yeah, the alternative is that you have huge sensitivity but low specificity. We've had Cochrane searches of candidates like, you know, 5,000, 10,000 citations to draw through, which is just dark, because you kind of lose any sense of perspective, you just go blind. The other thing is searching references of papers you do find and review papers you do find. We've found sort of upwards of about 30% of our papers from reference lists.
Yeah,
that's on top of the search.
Even
if you've done the search, you're still missing.
Yeah, so there's this kind of balance of having sensitivity, but also having it to be doable. And also, but citations always in the back are a huge source.
So then would you include that as part of the method? Would you like it that when you do a literature, systematic literature review, so the method will include database searches, small review, serendipitous, you would just include that as part of the search?
Cochrane certainly does.
And
I think the thing is
the flow diagram is just database search and then hand searching.
And you just have to adhere to your methodology and also to the Prisma flowchart to make sure that it's really clear and transparent about, you know, where you found the articles, whether through the electronic, and you're not judged in terms of that. It's just important for the reader to understand where that came from.
Jane, you have a question?
Oh, okay. Yep. Can they go to morning tea? Come up here, Philippa and Tim, because it's very hard, I think, for Newcastle.
Sorry. How long did it take me to do my systematic review?
Without the break.
Without the break. Oh, look, I would say it took, can I just say the whole process probably took me about 6 months or longer. But when I actually started the search and really, you know, was working, going through each database and identifying, that probably took me about 6 weeks. So it's the actual when I ran the search the second time, it took me about 6 weeks. Might even be a bit less, but no, it's probably about, because you've got to then go through and extract, review the abstracts and the titles, and then do the data extraction.
But I think you also need to probably qualify that by saying that was the first time you.
Yes, I had. Yes, and I guess having finished my systematic review, there's a part of me which would really like to do another one because of all that I learnt. But you know, because it takes so long, I think the first time of anything takes a long time. I'm sure I could halve that time, second time round. Thank you. Well, that's true. Yes. Yes. Yes.
But I think they take a long time to do them properly. They actually, even if you're not adhering to the gold standard of the Cochrane review, they actually a timely thing to do. And that's why Tim's slide with regards to the rapid review, you know, that like we're talking about, that we've been commissioned, because no agency could really afford to pay you to do a very a traditional systematic review or a Cochrane review, because it would cost so much and it would be so time consuming for you. So I know. So Newcastle looks like they're getting ready. They're dividing into groups, perfect, which is great, because I know when we were planning this workshop, Candice and Tim sent out an email and actually asked people to nominate their reviews. So did anybody in this room nominate a topic for a review? Oh, there's one courageous person. That's fantastic. And what was your review that you wanted to do?
I've got it.
You can't remember? Just the content area. Don't just. Okay, so need help. Perfect. So I'm going. You can stay there. So, is anybody in the Sydney room interested in working on a review around implementation e-health? Okay, I want you to join Ben at his table, and I'm going to get others to move around. So there's nobody else in the room that had identified a review.
The implementation side.
Sorry, implementation sites?
Deborah, Deputy
Yeah.
Okay, so Donna is interested in doing one on implementation sites. So if people would like to look at implementation sites, can you move to the table and join Donna?
So, a service-wide implementation of psychological/mental health interventions.
Is that Donna?
Well, that was a bit more specific. That was a bit too specific, I think, for this group.
Well, not
But just an
necessarily
idea,
to do. So Tracy's joining on here, are you, Tracy?
Yeah. And then we might have a
So
group.
Deborah, what did you have?
Deborah?
You wrote barriers and enablers to referral for cancer services in rural areas.
Oh, perfect.
That's great.
Okay,
Thanks,
that's
yeah.
great. So we've got 3 tables. I want you to just find a review.
Do you want to go?
So it'll be e-health, implementation, science, and barriers and facilitators for rural cancer referral. Right. And Newcastle, I can see, have actually organised themselves, and they wanted to do, Candace, I think, smoking cessation and
Another group, they've split themselves up.
but what's the other topic they're doing?
They're quite well.
Oh, okay, implementation science. Okay, so what we want you to do, thank you for moving into your groups quite quickly. So what you're going to do is that you're the team that's been configured to work with team leader who in their nominated areas. So that is Ben, Donna, and Deborah in Sydney, and I'll leave Newcastle because they look like they're very organised. What I want you to do in the next 35 minutes is actually define your search question, and then I'll put Philippa's slide back up again, or I'll get Candace to put that up, where Philippa had the PICO. So I want you to think about what's the patient group that you're really wanting to focus this review on, what's the intervention that you're actually interested in, and you start to think about the comparator and the outcome. So I really want you to start to define what are the key elements that you want this review to focus on. And I think I can just probably move down. I think it would be most helpful to, I'll put my glasses on, would probably help. Can you see that?
I don't know, do we have Pico? Which one was
Number 7.
Number 7. Oh, thank you. Okay, so we'll just leave, so think about your search question, think about your population, think about the intervention, the comparison, and think about the outcome. Tim, did you want to add anything to that? No? Okay, so please go. And
so about 30 minutes and we'll come back and have a quick report
and
back.
then we'll report back. And you could start, yes, that's probably enough for you at this point in time, and we'll just float around. So who Donna, did you want to?
I'm a lawyer.
But do you mind coming to the front, so in case Newcastle? Hi, welcome back. Newcastle, we're going to come to you shortly and get you to report, but we'll just start with Donna from Sydney.
Donna Gillies from Western Sydney LHD.
Yep, so Donna's actually, Donna's the person who's done, what, more than 20 Cochrane reviews?
Oh, yeah, something like that.
So, good.
So this was quite interesting because we've had a really free-ranging discussion, and it became quite nebulous at times, but I'm really pleased to say we seem to have something happening here. So I am used to doing quite more clearly specified intervention reviews, but what we were aiming at was looking at a review to inform organisational change, and particularly in mental health systems. So what we've ended up with is our population group is mental health organisations, but we're also interested in paralleling that with oncology services. So we thought we might look at both mental health and oncology organisations stroke services, and by services I mean in the broader construct. So for example in my service I'm talking about whole LHD services. The intervention is those interventions are aimed at organisational change, and we did look at a number of constructs that might inform that, because that could get bigger than Ben-Hur. So we were thinking about interventions that might be aimed at technology, at thought leaders, at guidelines and policy, training, enabling roles, and also using data to inform organisational change. And the outcomes that we thought we might look at was sustainability, because that is a major factor for organisational change, but also improvements, and those improvements would be specific to those interventions that are being implemented. And for our comparison groups, we will be looking at those interventional strategies versus each other, and to see which seem to have most evidence of effectiveness.
Wow, that's great. You're well on the road to...
So, Don, I think some of this came from the fact...
Do you want to come and talk about that?
I just found this really interesting, because we have been looking at opportunities to get some reviews up collectively. And I mean, I think what was interesting on this one was we're kind of saying, in the cancer space, Tim, Jane and I suspect some others in the room are on at least 3 major implementation programs going into cancer services at the moment. Totally uncoordinated. So only because we happen to be on the ground is the coordination happening really between them at the floor level. And so how do organisations actually, what interventions do they have to enable successful implementation of evidence-based practice interventions, but multiple of them at once? So how do they handle these kind of, so that you can actually say, we'll put the prompt project in, we'll put the cancer pain project in, and we'll have mechanisms to support them and sustain them in a systematic way. I thought it was quite an interesting project, but anyway.
And that's the review that you're planning to do?
Well, what are the how do organisations cope with multiple interventions and support implementation programs?
Yeah, wow. So you're going to do that, Donna?
Might want to take a little time.
Yeah, okay.
And people who would like to join in on the project, yes.
Yeah, it sounds great, and it's a hot topic. So the back table. So this is a table that was looking at rural cancer services. Is that correct?
Yep.
Sorry, I can't remember. Yeah, sorry.
I can't tell you.
Yes. I think our conversation was a good example of how difficult it can be to nail a research question, because we started off in one area and then we decided to go down a different track because we decided it was too difficult to hone in on that in terms of a review. So we started off looking at access to services, cancer services for patients in rural, remote, regional areas. And we wanted to look at how we could, I guess, further refine that and what we were trying to discover. I guess for the sake of this exercise, we were just making up a question, so it wasn't like we were coming from a particular angle, which made it a little bit more difficult. And so I think where we got to in the end was that we wanted to look at patients' access to multidisciplinary teams, so cancer MDTs in a regional and remote area. And then we went off down the track of what does that actually mean? So what is an MDT? What defines an MDT? What are the different models for MDTs? So it kind of turned into like this massive nebulous conversation of where do we go with this research question. So I think we decided in the first instance that we would probably want to do a review of looking at current structures of MDTs and how MDTs are run, what are the current protocols for MDTs, whether there's any evidence around outcomes, patient outcomes for being presented at an MDT meeting. And so as you can hear, we didn't really get to a really nice defined question yet. We were still having that conversation. But I think we, in the end we were looking at our population of having a population of adults in rural, regional, remote areas who had colorectal cancer and whether or not they had attended or been presented at an MDT meeting, and looking at those patients compared to those who hadn't attended an MDT meeting, and looking at outcomes in terms of clinical outcomes, care coordination outcomes, patient experience outcomes, and that sort of thing. Okay. If that makes sense.
Yeah.
That was like from a bit of a mess of came up with about 3 or 4 different ideas, and then trying to like hone it down.
And I think the point you made that, or what I think I heard you say was
how difficult it was to just sort of get focused. And I think the conversations I imagine you had are really what all of us have when we're doing systematic reviews, and you actually need to have those conversations to really be very clear about the population, the intervention, and what do you actually want to focus, and whether in actual fact the systematic review is in actual fact the best methodology. Because I must say, one of the things I picked up on in terms of you thinking about MDTs and how they function and things like that, in some respects that's almost like an environmental scan, but that's kind of for a topic for another day, because it may not actually really be written you may not necessarily find it in the literature, but you might find it in guidance statements.
I think for us the biggest challenge was deciding on what was the question that we were trying to answer in terms of access to specialist services for regional patients, and what were we trying to actually answer in terms of, what were the outcomes we were looking at, sort of thing.
So fantastic effort, so thank you very much. So Ben, did you want to come and share?
Maybe go to Newcastle.
Oh, sorry, go to Newcastle. Candice. I'm totally dependent on Candice to get me to Newcastle. So if you can just nominate who's the person at Newcastle, if you can just tell us about where you got to with your review, that would be fantastic. Oh, fantastic. Hi.
We had a look at a population of GPs who were treating adults with chronic non-cancer pain who've been on opioids for longer than 90 days. The intervention was whether those GPs were having a de-prescribing conversation with patients. The comparison, the outcome, well, the primary outcome was whether they actually were having the conversation. And then we had a bunch of secondary outcomes of the attitudes and the practices of the GPs and the knowledge of the GPs, and possibly the barriers to having that conversation. So the outcome section got a bit broader. And then the studies.
So we just lost you a little, right?
Just the last bit.
Just the last little bit.
Which part? The studies?
Yes, the studies.
All studies. It's not a it's not a well-explored area, so we thought at this point that all studies would need to be included.
Okay, thank you. It sounds like you made really good progress. Is that your feeling? Was it easy?
Well, everybody helped.
That's a great thing about themes.
Yeah, and it's I don't know. We'll wait and see. It hasn't really. It's a little way off.
Did you just do a quick Google while you were there? Because I'm just wondering, because that's a really hot topic.
Did you do a quick on what?
Yeah, did you just have a quick look?
No.
No, that's okay, that's fine. That's great, so well done.
Okay.
Thank you. The other table at Newcastle? You're on camera. Do we have a name? Thank you. Hi.
Hi. So we also spent most of our time talking about what the research question was, and then it almost seemed like every word in the research question, we all had different definitions and ideas on what even just the word in the research question was. So most of our time went into that. We started with talking about what kind of strategies could be used to help people in primary practice to develop interprofessional and collaborative networks. So we kind of started to look at what training strategies would be effective in helping people to establish those referral networks. And then we realized that perhaps there's actually two research questions. So the first one was what kind of interventions are available to look at those kind of things. And then once we had a list of what interventions we could study, to then do kind of another review that looked at which ones were relatively more effective than others. I think we mostly just focused on the research question. We did get to population, and we specified that it would be primary care service in kind of OECD developed countries, but that we wouldn't limit it to urban versus rural because we did want to see if there was a difference in the strategies that regional or remote services use to build those kind of networks versus a more metropolitan-based.
Okay.
No, that was it.
Oh, fantastic. Thank you. So I think at the beginning you said, did you say you found it tricky?
Yeah, so when we first started, it was about what kind of interprofessional training skills could be used. And then we thought, oh, we'd like to do that in community care. And then we had to specify what we thought community care was. And then we had to specify what kind of training strategies we thought that would be. So whether or not that was kind of like academic detailing or outreach or mentorship. So we did spend quite a lot of time talking about the actual words in the research question and how it differed between our backgrounds as well. So we've got an E and we've got advanced researchers and stroke researchers, quite different.
Okay, that's great. Thanks for sharing all of that. It just, I think your comments really illustrate the importance of really unpacking and starting to get some operational definitions that you're going to work to, but also to start to think about what are the elements of the intervention that you're really wanting to focus on and trying to define those as clearly and as tightly as possible. And that often takes quite a bit of time. So I think you've done quite well to have got those things listed down. So thank you. And thank you to Newcastle for your patience and working so diligently as almost like remote scholars. Ben, I'm wondering, did you want to, so we've just got one more table in Sydney to present.
So the aim of our review topic was to identify barriers and enablers to the implementation of efficacious e-health interventions. Obviously, e-health is a pretty broad umbrella, so for the purpose of this exercise, the specific interventions that we decided to focus on were web-based self-management interventions, which could be delivered with or without therapist support. The population that we were interested in was cancer survivors, so defined as people who've been diagnosed and completed active treatment for cancer with no evidence of residual disease. In terms of comparators, I thought it would be interesting, or we thought it would be worthwhile perhaps comparing outcomes for self-directed versus therapist-assisted interventions. And the outcomes that we're specifically interested in were not so much efficacy, because there are already reviews out there pertaining to that topic, but more looking at effectiveness, I suppose. So what factors are involved in the general kind of uptake and adherence and subsequent usage of e-health interventions. So we'd be looking at more not so much at kind of tightly controlled RCTs, but more broader effectiveness-focused studies.
Thank you. So do you want to share your experiences to getting to that point?
Jane basically came over and interrogated us. No, it was there were some very useful suggestions, obviously, and Jane really helped us think about you know, the broad spectrum of interventions and what we wanted to focus on, and also the, you know, even within a cancer setting, there's, you know, people who are you might want to focus on preventative kind of measures, or people recently diagnosed, or people with advanced disease, or survivors. So it's really important to try and narrow down the focus of the question to make sure that it doesn't get into this broad nebulous kind of review that will never happen.
I'm sorry if you felt interrogated.
No, it was all good.
Intimidated. Yeah, I think, thanks Ben, I think, they're the things, they're probably the robust discussions that I think you really need to have when you're sitting down thinking about a systematic review, and it's always better to do it as part of a team. I think all great research happens in teams, and it's great to work in an interdisciplinary team if you have that opportunity, because you get different perspectives about what different disciplines think about what's important in terms of the subject. So just probably in summation, you have been on a very rapid tour of the systematic review galaxy, but it's by no means a complete tour. Many of the things that you wanted us to discuss and highlight, we've probably touched on, but if I go to the board, and apologies to Newcastle that are unable to see this, I think we've, Philippa sort of touched on the search terms just very briefly, and I think both Tim and Philippa really highlighted, I might just shut the door, Philippa and Tim really highlighted the importance and the value of actually meeting with a librarian. And for those of you that actually work in hospitals, my preference is actually the hospital librarian, because they're more immersed in the clinical minutiae, I guess, of life. I find them particularly incredibly valuable. And many hospital librarians, they love doing searches because many of them are actually quite we're probably underutilised, and it's really a great thing for them to get involved in. They often really like it. We haven't really touched on too many of the databases, but you really need to get a handle on the database that's most relevant to your work. If you are actually working in palliative care, there's a fantastic palliative care database which is called Care Search, which basically is publicly available. I would get you to hop onto Care Search. Just go www.caresearch.gov.au and look at finding the evidence. It'll do a PubMed search, and you can actually develop your own search strategy there. We have touched on the quality assessments. We could have done a whole 2 hours on really just all of the different assessment tools out there. There's a huge number of different assessment tools, and I think both Tim and Philippa spoke to that. I think Tim actually did a really nice overview of some of the approaches to the way in which you need to synthesize the data and some of the things not to do, and we would recommend you get on to the website and actually look at the POPAY paper. Time is of the essence. We heard from Philippa, her review took about 6 months, but remembering that she was a new PhD student. I think the other thing is I think we've probably really highlighted the reviews that you do need to have rigour, but often what you started to experience this morning or just now is actually part of the iterative process that you really need to invest in up front to really make sure that your questions are right, what the search terms are the best they can be, and that your methodology is as robust as possible, and that you've got a good audit data trail, and need to really always stay true and focused on the questions. And we did allude to some of the efficient ways for data extraction. As I mentioned, we've used EndNote a huge amount. For one of our students is doing a huge systematic review, and he's actually ended up using NVivo to actually manage all of that data. And I think next time we do a meta-synthesis, that's probably what Tim's nodding, that we've agreed that we will do. And it's been amazing what this I love having PhD students. What our PhD student has taught us about, how to exploit in vivo to manage this huge data set. So I just also want to thank Newcastle. It's been great to have had you on board. I hope you got something out of it. As somebody who spends half my life in rural Australia, I admire your tenacity. It's not always easy living and working outside the metropolitan area, but thank you for participating, and we'll be interested to hear your views and the way in which we can make it more interactive. And thank you to the audience. Thanks for your participation, and we wish you well with your whatever review that you decide to do. And if we can help, please don't hesitate to contact us. So thank you.
Thanks, Jane.